The management of cataract in patients with uveitis is often a challenge due to pre-existing ocular comorbidities that may limit the visual outcomes compared with non-uveitic senile cataract. Cataract is the most common complication in patients with uveitis, which develop as a sequelae to recurrent intraocular inflammation and or chronic usage of topical and systemic corticosteroids. Its incidence in patients with uveitis ranges between 8.5% and 35% in a heterogeneous group of uveitic entities. Uveitic eyes account for approximately 1.2% of all eyes undergoing cataract surgery. Cataract is responsible for 40% of all cases of visual loss among patients with uveitis. Moreover, it is the most common indication for surgical intervention in uveitic eyes. Surgery is often challenging because of the patient and ocular factors. Successful surgery aims to reduce the occurrence of commonly cited postoperative complications. Regional anesthesia such as peribulbar block should be considered for patients' comfort to avoid pain during iris manipulation. Band-shaped keratopathy is common in chronic anterior uveitis and juvenile immune-associated uveitis. Removal of BSK to be done first, followed by cataract surgery. Corneal epithelium is debrided, followed by application of cotton bud soaked with EDTA solution over it for few minutes. The chelated material is debrided or scraped either with a blade or forceps. The small pupil makes access to the cataract difficult. The first step is using balanced salt solution with adrenaline through the paracentesis site. Use the same cannula to release the posterior synechae along with injecting the adrenaline. Staining the anterior capsule with trypan blue dye should be used to enhance visualization during capsulorhexis and differentiate the anterior capsule from the pupillary membranes, particularly if there is a matured white cataract or a corneal scar. If the cataract is complicated with broad segmental posterior synechae, it is recommended to inject dye under the iris to stain the anterior capsule before any type of iris manipulation. Dispersive or viscoadaptive ophthalmic viscoelastic devices sometimes may be enough to push the pupil wider. However, if the pupil does not dilate with OVD, it can be mechanically stretched using two Kuglen hooks 180 degrees apart using push and pull technique to widen it in the horizontal and vertical meridians. However, if the iris is thin and atrophic, it is advisable to avoid stretching the pupil forcefully as it can rip. Self-retaining Grishaber iris hooks placed through 4 sub-1 mm paracentesis ports in a diamond pattern are very useful, as it is possible to adjust the amount of tension applied on each hook for adequate pupil opening size. Iris hooks are suitable for eyes with a small pupil and shallow anterior chamber. Entering anterior chamber in this situation is difficult as iris keeps prolapsing out from the side port. Using iris spatula from other side port to keep the iris down while entering will be a useful technique. For a deep anterior chamber and with a pupil that is not scarred or atrophic, the Malugin ring can be considered. It is inserted into the anterior chamber and hooked to the iris. It has advantages of minimal sphincter tear and adequately dilated pupil without shallowing of anterior chamber as seen with self-retaining iris hooks. If there is a total membrane occluding the pupil, the membrane has to be dissected first, removed, and then the capsulorhexis can be done. With ophthalmic viscoelastic device in the anterior chamber, a 23 gauge microforceps scissor is used to engage and grasp the pupillary edge. Later, the membrane is cut from the pupillary margin in curvilinear fashion to open the pupil. In cases with dilated pupil with no posterior synechae, as in case of Fuchs uveitis, forming the anterior chamber with an adequate OVD amount is necessary to flatten the anterior capsule and control the capsulorhexis edge to prevent radial extension, given that most of these patients are young with elastic capsules. If the capsulorhexis runs out to the extent that it is not retrievable, give few beer can cuts adjacent to the extension, raise a new capsular flap and complete the capsulorhexis. In case of intumescent cataracts, a single nick in the capsule can tear the capsule radially due to high intralenticular pressure. In these cases, give a gentle nick in the center of the capsule, aspirate all the intralenticular fluid slowly in batches and then raise the flap for capsulorhexis. Use of capsular forceps gives a better control in these cases. A femtosecond laser is valuable for performing central and well-sized capsulorhexis in these challenging situations. A continuous circular central capsular axis with a diameter of 5 to 6 mm that covers the edge of the IOL optic is recommended. Hydrodissection and hydrodelineation are important steps given that most of the uveitic cataracts are soft, which allow for easier nucleus removal. Phacoparameter settings should be lowered in soft cataracts to avoid post-occlusion surges and posterior capsular ruptures. Further, irrigation and aspiration should be thoroughly performed to remove all cortical materials, along with adequate polishing of the anterior and posterior capsules, especially at the equator, to reduce the risk of severe postoperative inflammation and posterior capsular opacification formation. Ultrasound biomicroscopy helps in the decision making of uveitic cataracts associated with hypotony. Ciliary body edema or supraciliary effusion on ultrasound biomicroscopy will respond to adequate dose of systemic corticosteroids. Once the intraocular pressure raises and inflammation subsides, these cataracts can be successfully operated with phacoemulsification and intraocular lens implantation. If ultrasound biomicroscopy shows pars plana membranes in more than 2 quadrants associated with traction on the ciliary body, pars plana approach of lensectomy with vitrectomy will be the surgery of choice, followed by aphakic correction. Here, the rationale of surgery is to clear the capsular remnants and remove the membranes over the pars plana and ciliary body area. This membrane can be removed using a cutter or a scissor to relieve the traction and open the ciliary processes. This technique helps in the building up of intraocular pressure in post-operative period. In pediatric eyes, besides the small pupil, the anterior capsule is more elastic, and there is general agreement that primary posterior capsulotomy with anterior vitrectomy for children aged less than 8 years is required because of the imminent posterior capsular opacification soon after the surgery. Most surgeons would advise to avoid the intraocular lens in uveitic eyes of children below 2 years of age. In conclusion, cataract is a common complication in uveitic eyes requiring special consideration and care. Its management in uveitic eyes requires proper preoperative evaluation, meticulous surgical approach, and careful monitoring of postoperative complications. Good outcomes can be achieved after overcoming all these
Thank you so much for coming today to the Eye and Contact Lens session. My name is Joanne King. I'm the Scientific Chair of ECLA, and my fellow moderator, Dr. Deepinder Dhaliwal, is here with me, our former president and board member. So just briefly, please be on the lookout for future ECLA events. We are an organization focused on contact lens education and related anterior vision segment science, working together with all eye care providers, including optometrists. Please also look out for our Eye and Contact Lens Journal, headed by our chief editor, Dr. Deborah Jacobs, and our C-Core online curriculum for ophthalmology residents for contact lens education. So we have a very wonderful event today with a lot of speakers, amazing speakers. And so without further ado, I'd like to, Dr. Dhaliwal will introduce our first speaker. All right. So we are going a little bit out of order today due to timing constraints, but we have our special named lecturer, Dr. Marjan Farid, and we are so thankful that she is here today to speak with us. She is a professor of clinical ophthalmology and director of cornea, refractive, and cataract surgery at the Gavin Herbert Eye Institute, University of California, Irvine. She has many awards, numerous awards to mention, and she is the chair of the Cornea Clinic Committee of ASCRS. So thank you so much for coming and speaking to us today about management of severe autoimmune-related ocular surface disease in a cataract patient.
Okay, so I didn't realize we were going out of order. So if introducing Marjan, I definitely want to get in on that. Marjan, enough of all that.
But we also get an increase. We are all very be a leader in the field. So thank you for everything you have given to our field and paving the way. So thank you. It's an honor to be here. Okay, enough of all the happy talk. Okay, so again, it's a big honor for me to be here and to give this talk. Dr. Lindstrom is also a mentor and a giant in our field and has done so much for corneal and cataract and refractive surgery, so it's really an honor to be giving this lecture in his name. So we're going to talk about management of severe ocular surface disease, mainly, and relating that to patients who are in our workflow for cataract surgery. These are my financial disclosures. So I'm just going to step back for a second and just talk about the impact of ocular surface disease and just even dry eye disease in the surgical setting in our cataract patients. And we are all very familiar with the many studies that have really shown us that dry eye disease, ocular surface disease lead to potential errors in preoperative measurements that we use for cataract surgery. So our topography measurements will be off, our keratometry, our refractions, aberrometry will be significantly altered. But we also get an increased risk of infections. We know surgery will worsen ocular surface disease and symptoms and lead to patient dissatisfaction. There was a 2020 global consensus on patients who have corneal irregularities in the preoperative cataract screening. And the consensus that was come to by everyone on that panel was that a really good slit lamp exam of the cornea and corneal topography and tomography are really essential in the preoperative setting because lots of corneal irregularities can go and be missed. In response to sort of ocular surface disease in the preoperative setting, the ASCRS Cornea Clinical Committee put together this algorithm. Dr. Chris Starr is going to go through this extensively, so I'm not going to talk about it much, but essentially the goal is in patients with preoperative ocular surface disease, you really want to address that. You want to reduce surgical delay time. You want to get best surgical outcomes and turn around that tear film and epithelial health as quickly as possible. This often requires an aggressive, multifaceted approach, optimizing the lipid layer, treating lid margin disease, decreasing inflammation, and healing the ocular surface epithelial irregularities. Now, what about patients with very severe or autoimmune-related ocular surface disease? So these are not your run-of-the-mill dry eye patients anymore. These might be patients who have severe ocular surface autoimmune-related disease, rheumatoid arthritis, graft-versus-host disease, Stevens-Johnson syndrome, pemphigoid disease, severe atopic disease, chemical burns, contact lens-related keratitis, and patients who have been on chronic toxic drops for many years, all of which have resulted in some degree of limbal stem cell deficiency. Well, these patients are often very inflamed. Inflammation is really the hallmark, and you can't not treat the inflammation. So often these patients will be positive on
Just again, as we're starting here, please make sure you have 3D glasses. If you don't, they're available right outside the door. And I think we'll get started here. So welcome, everyone. I'm David Chang, and this is a course on really getting yourself to the point where you feel comfortable with chopping. So I know we have people that have tried or done some chop and looking to improve, but this is really the goal, to give you the practical pearls to really, really learn to chop. And once you'll be able to improve on your own. And I have to say that, of all the things that, looking back, helped me the most, I became a totally different surgeon when I learned to do phaco chop. And so nowadays, if you can learn that close to the time of your residency and so forth, that's really valuable. So these are my disclosures. It's basically all the instruments you see, nothing at all I have a financial interest in. Now, if you're serious about it, this course will help. This is the only place now that we can see 3D video because the Academy no longer allows 3D projection. But the textbook, we actually have a lot of these videos on a disc, but what helps, I think, here, and it just took a lot of work to put all this together. Half of it is on complex cases and half is on chopping, but it's really kind of breaking down each moment and each pearl and what are the problems that come up and how to get out of them, okay? So this is available through Slack. I donate all my royalties, and nobody does a book to make money. There's so much time involved in it. But when people come up to me, the course maybe helps them get interested, but they really tell me that the book is really what got them to the point where they became comfortable. But this is going to be practical. Now, first thing is the terminology, because when we started the course, in 1997 or 96, around then, there were so many different methods and types of chopping, it got very confusing. So we kind of broke it all down into horizontal chop and vertical chop, and that terminology started in our course. In horizontal chop, the chopper and the phaco tip, the initial chopping motion, it's in the horizontal plane. So you're reaching around the equator, chopping the center, that's what we call it horizontal chop. In vertical chop, you're impaling the nucleus, you're lifting a little bit, and the initial movement of the chopper is down. And it's kind of like 80% is down and 20% is lifting. It's not 100% down. If you lift a little bit, that will help you, particularly with a denser lens, because you're creating a little more momentum. Once you break through and chop, you always kind of pause a little bit, and then you move your tips apart, and that's what propagates the fracture through the rest of the nucleus to divide the nucleus in half. That part is all the same. Always try to stress is how do you hold the chopper? And it's your thumb and your index and your third finger is how you hold things. And that means you use your fifth finger to try to put it on the side of the patient's forehead or cheek or something like that. And that is where all the energy goes. So you need support for your wrist here and your fifth finger. So those 2 points are your stability. Yeah, it may be nice to have something for your arm as well, but what makes your hand still isn't your nerves of steel, it's that you simply have 2-point fixation for your wrist and your fifth finger. And then these fingers don't have to do anything that requires any strength. And you want to get to the point where you're holding the chopper and it's the tips of your finger that then can maneuver it. Going through your tome, just to get you a little bit started here. One of the things that helps is I'm not stirring up the cortex. So I have to touch it gently so I advance it, but I don't stir up the cortex. Because once I stir up the cortex, like at the end there, I can't see. And when I do the hydrodissection, and this I have no financial interest, in the Chang cannula, which you can get from Catino, which is now Corza. Let's do the next one. It'll help with hydrodissection. Now here's the first wave. You see the wave, and then I push the nucleus back, and I turn the cannula tip slightly inward, and that wave is hydrodelineation. And the reason it's important with CHOP is you cannot chop the epinucleus. It's too soft. Now, this is horizontal CHOP. I'm aspirating the epinucleus, and then I impale the nucleus. This is the Seibel vertical chopper. And once I lift a little bit, I depress 80%. There's the fracture. I have to wait, and then I separate. And you can see way down at the bottom there's our clear red reflex. Now, because I'm not going under the CCC, I can simply keep rotating. Doesn't matter which direction, but with vertical chop, it's a little easier counterclockwise. And I'm just sort of cutting all the pieces, like I cut a pizza into all the pieces before I take out the first slice. So that is vertical chop. And now, because all the pieces have been fragmented, just like the pizza from the box, we take one slice out at the time. If it's a little bigger, we cut it into smaller pieces. And it doesn't really matter what order you do things, but the principle is you don't want to try to be phacoing something too large because it won't go into the phaco tip, and it'll tend to bounce away, and that repelling of things around the anterior chamber is what will tend to cause endothelial cell loss. At the end now, you can see I'm kind of lifting my phaco tip a little bit higher, and that's the epinucleus, and it comes out all together. And why did the epinucleus come out easy? Because of the hydrodissection. Can we do 03B now? Yes, and so this is, for those that haven't seen it, Zepto. I actually do consult for them, and what it is an automated capsulotomy without the need for a femtosecond laser. So it folds, goes through a clear corneal incision, and then that rod comes back, and the ring itself is nitinol. It doesn't cauterize, it vaporizes. So there's a heating. It's a very instantaneous, brief moment of heating, and that causes vaporization, and you'll see a little bit of just a subtle jolt here in a moment. I've applied suction. That was the cut, and instantaneously 360 degrees around, I release the suction, and I have a complete capsulotomy. So I think what's going to make this really nice now is they've developed a system where the vacuum you're going to use is from the phaco machine as well as the energy. So you'll be able to attach it to any phaco machine, and that's Zepto. We'll go to the next one, and let's talk about horizontal chop in a soft to medium cataract. Now here's the hydrodissection. So I did the Zepto. Now, that's going to mean the nucleus rises up, so I do have to push the nucleus back. Otherwise, the nucleus seals the back of the CCC, and you'll trap fluid. That's called reverse capsular block. And there you see the round capsulotomy. All right. Now, I think we're probably now going to have 4B next. And this is showing horizontal chop. Now, why am I aspirating the epinucleus? Because that's deceiving. Now I can actually see where the endonucleus is. So it's kind of like if you have a sidewalk and leaves on it, you have to blow off the leaves. Oh, there's the sidewalk. I chop directly toward the phaco tip. I bisect the nucleus in half. Then I rotate clockwise a little bit. I make my second chop, which doesn't have to go all the way through, and I've created the first pizza piece, this triangular piece. I aspirate it, and now I'm going to aspirate a little epinucleus so I see where the nucleus is. I go deep enough, I go around the edge, and so the nucleus doesn't look so big like this when you hydrodissect, and it's soft because you realize so much of it is epinucleus. And this is the reason why hydrodissection, so hydrodissection is to loosen the cortex and the epinucleus. Hydrodelineation separates the epinucleus from the endonucleus. And why would you say is that even important? Again, it's because of the fact that I cannot chop the epinucleus, so it's not going to be divided. I can chop the endonucleus take out the fragments. This is the lens disassembly concept. And now, if I did a good job of hydrodissection, I have loosened this this epinuclear shell, which is very thin in this case, but I don't have to struggle too much because I've broken the epinuclear capsular attachments, and there it comes, and the cortex will be easier to remove as well. All right, we'll go to case 5, and we'll do another horizontal chop all the way through, just so you see this. All right, so the first step is let's see where the endonucleus is. Now, I'm going to I want as much nucleus between the two instruments when I do the chop. So that means make sure the phaco tip doesn't go too central. I aspirate here. I'm passing right under the CCC around the equatorial edge. And so this is the micro finger chopper. That's the Chang horizontal chopper. Again, Katina was purchased by Corza. There's another version if you're a left-handed surgeon and hold it in your right hand. And we go around the edge. Now, what you're noticing is once I've got a heminucleus removed, I can then pull that piece more centrally and then reach around it. And then I don't have to put the chopper way out in the equator of the bag. You may wonder, why is the shape of it that way? It's to basically claw and fit around the edge, the equatorial edge. And if you put it at the 45-degree angle, which is where I have here, it will line up exactly where it'll conform to the equatorial edge. Looks like we're going to go to number 6. So what I did here is I filmed it with a wide-angle view. So this time, look at the angle of the instruments. Now, this 3D does exaggerate it. So you see how, in order to get the tip down, I have to lift the handle up, right? It's a rowboat. To make the oar go forward, you have to pull the handle backward. So it's the opposite. And it helps to not get too much zoom when you're learning, because you'll be able to see a little bit more of the relationship of the instruments and the angle of approach. You can see yourself right now. You can tell much more. Am I pushing down on the side of the incision? You know, and so this is the advantage for doing this sort of wider angle view. You can see how, again, it's exaggerated 3D. But again, to lower my phaco tip, I have to raise the handle. I can't just lower the whole instrument. And I think you all know this, but of course we all had to overcome the natural tendency to move the instrument handle in the direction we want the tip to go. It's the opposite. This becomes really important with all types of cataract surgery, but it's very important with CHOP because you can't see otherwise. All right, so then we lyse it. So what we're doing is using pure mechanical energy to fragment the nucleus into multiple little pieces. We're not using a lot of ultrasound energy to sculpt grooves. In addition, we're not putting stress on the capsular bag, because what braces the nucleus and provides counterfixation is the phaco tip. So all the manual mechanical energy is directed one instrument against the other, rather than requiring the capsular bag and zonules to support things. All right, so there is the epinucleus. And again, if the hydrodissection was good, it's going to pop out very easily. And hydrodissection, being really good at hydrodissection, is going to be really important. Now look, I am going to go back and touch the posterior capsule. And this is something I recommend that you do, because for many people, they look at that chopper and they go, that thing is scary, and there is no way I'm putting that in the eye. But look at how out of focus the shaft is. And you will get an idea at this point that, my gosh, how big is the capsular bag when the nucleus is there? It's rather deep. Let's go to the next one. All right, so this is a little bit of a denser lens. I believe we're on number 8. So there's the hydrodissection. Hydrodelineation, you can't really see it, but what I'm doing is I'm rotating the tip. For hydrodissection, I want it parallel to the CCC in that plane because I want the wave to follow the contour of the capsular bag. Here, I'm now using viscoelastic, and this is a real nice trick to push aside the epinucleus and cortex. So it does two things. It elevates the anterior capsule so I can find my way around it, and also pushes the cortex aside. Now look at how deep I have to go. I pull the sleeve back so I can penetrate deeper. And I have to be a little more slow and deliberate, and a little bit more of a sideways separation movement. But now I have bisected that with no sculpting, with minimal stress to the zonules, because all of that force, and you can see me feel the force and pushing, is going directly from the chopper toward the phaco-tip. And that is why this is going to be such a better technique when you master it for the dense nucleus, for the zonulopathy case. All right. So here I am aspirating that. I pull it up, and now I can subchop. So the first thing is to fragment it enough so that you can get the pieces out of the bag. And then there's a second stage when you have a large nucleus where you're going to subfragment or subchop those fragments into more bite-sized pieces. When you think about a technique, think about how you would eat a huge steak. You got a fork and a knife. You could cut it in half. You could cut it in quarters. You could cut one piece at a time. You could carousel it. You could cut it into 6 pieces, but then you have to subcut that meat so that you don't choke on it. And if you have a smaller phaco-tip, that would be like your children. It's a smaller mouth. You'd probably cut it into smaller pieces. Here, the issue isn't that we choke, like with too large of a piece of meat. It's that if the fragment is too large relative to the lumen of the phaco-tip, it's going to be repelled away, and it's going to bounce around, and that's the mechanical trauma that causes endothelial cell loss. That's correct, and I chop through, and then I'm back down. So you can see with the denser lens, it's deeper. The depth is really important, so obviously you don't start with a case like this. But once again, you can see there's no sculpting. All the ultrasound is in the safest place, center of the pupil, halfway between the posterior capsule and the cornea. And that's the supracapsular plane. But we first got the nucleus out with minimal stress on the zonules. Now, at the end, you got to slow down. There's a tendency, it's like, oh, this is the easy part, and you sort of speed up because you're now feeling really good. It's actually the most treacherous part because, particularly with the dense lens, there may be zonulopathy, and if you don't have good centrifugal pull from the zonule stretching the posterior capsule, it kind of wants to fly up to the phaco-tip, just like a sail that isn't trimmed. You know, when we say a sail is trimmed, that means it's taut. And if it's not, the sail is, we say in English, luffing around, and that is what's treacherous. So that's why you have to sort of really slow down at that point. All right, now let's see. The next one is a small pupil. Small pupil is, again, one of the payoffs because basically now we have to make sure we are deep enough when you do divide and conquer. And how do you do that? Divide and conquer, you need to see the red reflex, you know, kind of gets brighter and brighter. That's now how you know you're approaching the posterior capsule. Whereas, and I kind of nudge the nucleus, and look how far away I keep my phaco-tip. It's exaggerated with 3D, but I really do point it downward because I want to have as much nucleus as possible in the path of the instruments, and it's a feel. So once you've done it enough, seeing it, then you realize I don't need to see where the chopper goes. I normally won't. It'll be behind the iris, but you get a better knowledge of the anatomy, so you kind of know about where the edge of the nucleus is with a softer nucleus, it's not further out. With the brunescent one, it's way further out. But again, the fact that it's a mechanical, more kinesthetic procedure, it's not as visual in terms of seeing the red reflex, it tells me the depth. The fact that I do all of the ultrasound in the center of the pupil, so I'm less likely to buzz or aspirate the iris, which is what the problem is with a small pupil case when you do divide and conquer. Huge advantage when you have small pupils to be able to do horizontal chop. All right. Then at the end, it's going to look the same. It's, basically, there's the epinucleus. So obviously really important here to have, turning off my light here, mobilized epinucleus. And this is where you look good, but it's all because of the hydrodissection. All right, I think the next one is a little bit more hydrodissection. Now watch. It's parallel. You see the wave there. I try to do it in real slow motion. I break the capsular block by pushing down. Hydrodelineation, you don't see a wave. It's too fast. But the payoff is here. When you pull on the cortex and it just kind of all separates easily, that means I hydrodissected well. And what the wave is, it's because there is resistance. If you're in the right plane, the fluid wave is really pushing against the cortex, and that's what slows it down and allows you to see the wave. All right, the next one is transitioning. All right, so how do I transition? Let's talk in a stepwise fashion. The easiest part is the last fragment. The hardest part is cutting it in half. So if we could learn the steps in reverse, it'd be a lot easier. So if you're doing divide and conquer and you have these fragments, pull them to the center and practice chopping there, because now you have direct visualization. So I have a heminucleus, I'm going to pull it to the center, and now this is the correct orientation. And I'll show you incorrect. That's incorrect, and that's correct. So this is giving you a direct visualization of what should be happening within the capsular bag, where you're hugging the external edge of the equator of the lens. But because I started chopping it when it's not underneath the iris, I have a good view of it. And so again, this is like a claw. Correct, incorrect, correct. Go right toward the phaco tip. Don't go to the side, because otherwise you don't build up any compression force. It'll simply rotate. All right. So this gives you a little bit of a mental picture of what should be happening behind the iris when you can't see. That's the advantage of chopping. So you can just do divide and conquer, and instead of just gobbling up the quadrant, chop it like we're doing here. That's incorrect. That's correct. Coming up here, you see how it just like a claw hugs around it? There you go. Now, some people just look at that chopper and say, well, man, that thing is dangerous. So the first transition is try something like the chopper, but do it for divide and conquer. All it is a bigger spatula, and after a while, you become used to that, and then you do that exercise that I said, which is when you just have epinucleus, you can put the chopper in the bag and go back and touch the posterior capsule, and you kind of go, wow, there's quite a lot of room. So here I'm using a little bit of a backhanded motion to slide it, and again, because of the good hydrodissection, that cortical shelf is really mobilized and a lot easier to remove. So I always have my phaco incision temporal. I put my side instrument 45 degrees. What are the reasons for that? Well, number one, if it's always in the same place, it's easier to find. Here there's a little bit of blood, but a lot of times you don't even see any blood. You can't even see it. But if it's always 45 degrees, then you kind of know about where it is. Secondly, if you're less than 45 degrees and your hands are large enough, your thumbs bump into each other. And if it's more than 45 degrees, it means you have to lift your left elbow, and that becomes very, very tiresome. So 45 degrees is not only easy to find, it puts your hands in the right position. All right, I'm going to turn my flashlight on here and see what's next. Okay, so I think we're going to do 12C now. So Stop and Chop was sort of a catchy term used by Paul Koch when we started with this, and that is you do your divide and conquer initial trench. So this part and depending on how soft or dense the nucleus is, depends on how wide it is. Is it for a medium nucleus? It's 1.5 tip diameters is the trench. If it's a denser nucleus, it should be 2 tip diameters. If it's really soft, just 1 tip diameter. All right, so remember now, here's where you practice using this as a second instrument. And it's a really good second instrument because it gives you a good lever arm, and you can really apply pressure a little deeper in that notch, which is harder to do with a spatula. So now we're going to finish the trench, do the back side of it, and you now have created a little groove or a trench right through the middle. That's why they put a groove into tablets, pills, makes it easier to snap them in half. And a little bit of pressure. And so now, normally you create quadrants, but Paul Koch talked about Stop and Chop. So what you're doing is reaching around the equator with a chopper. The first time now I have to put it under the rexus. There it is. But I chop into the center. But why is it easier? Well, I only have to chop the radius, not the full diameter of the nucleus. Secondly, I'm guaranteed to have my chopper deep enough because I've created this big trench. I just have to go up in the side of it. And then third, it's a much smaller fragment, so it comes out. Now, once that first fragment is out, it becomes easier. We're going to go to 13 video now. So this, I believe, is going to show a half trench. This is a denser